much more experience with dealing with, let's say, head injuries, which could very well be more emergent and stabilizing that C-spine than a local doctor who doesn't necessarily deal with that, who's just covering a game. So in that respect, if it appears as if, beforehand they'll want to know who's got more experience and who can take over and to take up and direct that process altogether.
That's interesting that you, as an orthopedic surgeon or orthopedic doctor, that you said that I may have more experience than a doctor covering. I would have honestly never expected you to say that.
Well, when I say that, it depends on what level. So if you're at a professional level, you usually have some type of emergency medicine doctor or a primary care doctor who does with the medical aspect of side of things, but you may also have an orthopedist. And there's different types of sports medicine doctors out there. So myself, I'm primary care sports medicine based, but you may also have an orthopedic sports medicine based doctor who's out there. Sometimes in the more professional leagues, you'll have a whole team of different subspecialty type doctors who will be able to take care of different type of aspects. So depending on what level you're at, especially maybe at a high school level, you never know who's going to be out there, what type of doctor may be out there. It could be any type of healthcare professional for that matter who may be covering a football game.
That reminds me, one of my colleagues is actually one of the physicians for the Houston Texans, and he's an ER doctor just like me. And his responsibility on the team is in case anyone goes into cardiac arrest. He is there. His responsibility is to carry the defibrillator. And so, in the many years of the NFL history, I don't think there's anyone that's ever had.
He gets to watch a lot of good football.
Exactly. So that's his responsibility. But in his mind, he's like, well, I can't screw it up. I don't want to be the first doctor who let an NFL player die because he couldn't revive him.
The officials are the ones you need to watch.
Exactly.
So I have a question, and it's for both of you. You get a call on the radio. You pick up a chart out of the door, off a patient's door. What makes you nervous? What would be the scenario that, in your experience, you're like, oh, I've really got to be on my game? For me, it's head injury. I don't mind this potential C-spine. It's, spine mortem syndrome. But what makes you what would kind of get your nerves up a little bit if you heard this coming in on the radio, or if Dr. Lee, if you saw a patient's chart on the door as you walk in the room? What do you think, either one of you?
I mean, my nightmare patient I've been through a lot and seen a lot. But the only thing I worry about in terms of patient is someone who's morbidly obese, 4, 5, 600 pounds and can't breathe, and they need to have an airway inserted. Normally we have equipment that we use, it's called a laryngoscope, and we can put a tube down in, 99% of people. But, those morbidly obese patients are very difficult to take care of. And even in terms of getting an IV in them or getting any kind of vascular access is very difficult. So those subset of patients, I always worry. I don't know what it's going to be. The heaviest patients I ever took care of was about 650 pounds. He was very sick, and the medical equipment at the time, it's starting to catch up now, but CAT scanners and X-ray tables were never meant for that level of weight for a patient. In my career, those patients, when I first started out, actually we had to transfer them to the zoo to get CAT scans and things like that, because that was the only place in the city where they had equipment that was meant for that level of poundage. And so definitely any morbidly obese patient with a breathing problem, it kind of makes me nervous.
So on that note, from a clinic perspective, it's going to be something similar to that, but depending on what we see in the orthopedic department, as far as emergencies are potentially arising, obviously it's someone with shortness of breath, anybody with, we look for potential leg clots, okay, or deep venous thromboses. Those could break off and go into become a pulmonary embolus, for example. Those could potentially be emergencies. And so the problem with being in the clinic is we don't have what we have accessible in the emergency room. So the ancillary tests, in order for us to make those diagnoses, other than when they're already going downhill or they're starting to change, and what we look for is their vital signs. So Vital signs are exactly what they say. They're vital signs. So anytime we see a patient in the clinic, we want to look at what's going on there and be able to see if there's anything that may be alerting us to where we may have to send them to the emergency room for further testing.
All right, so I kind of missed part of this when we were talking about fractures because I was answering the phone. So I once went to a workshop, and it was a orthopedic surgeon, and he said, if there's a dislocation or fracture, I don't mind you trying to reduce it, say like an ankle dislocation or, definitely fingers. We do those often, but he said that I don't mind you trying to reduce it by straightening it out. How do you guys feel about that? Because usually if there's a fracture, if you reduce it or, put it back in place, it causes a lot less pain. But then I know that it can also cause damage, cutting off circulation or that kind of things. How do you feel about that? Dr. Lee, why don't you start?
Well, obviously we have to check their ABCs and really for that it's more of the nervous and the vascular compromise to see if any of that is compromised. So if we can, I have no problems with if it has to be emergently done to go ahead and try and do it to help that patient out. Mm-hmm. Now, once that's stabilized, by this time you've already called 911. You've already got them taken care of. We have a plan as to who's going to go ahead and take care of them afterwards. So as long as Dr. Lean said, is from athletic trainer's perspective, is to try and stabilize that patient, and that's part of the whole process of stabilization.
So in your opinion, it's okay if it helps stabilize the patient?
Absolutely.
Or if you'd have compromised nerve or circulation.
Dr. Lean, any other?
Yeah, I think that really depends on the professional judgment and training of the person who's trying to do the reduction of the fracture or dislocation. We live in a society where if you do something and you cause more damage, you'll eventually find out about it, through the legal system. So I don't think anyone would necessarily take the risk to do something that they weren't 100% comfortable with. So if you're in a situation, it's for example, even though I'm a physician, I would never imagine doing a C-section or doing heart surgery on someone. And so it's the same thing. If you are an athletic trainer, but you have enough experience with fracture reductions and dislocations, then by all means go ahead and do it. But if you are not that comfortable and you're just kind of trying something out, I just saw this on YouTube, let me see if it works, then, then I wouldn't advise it.
Yeah. I guess a lot of it comes to what's in your scope of your practice, is the term that we probably hear quite a bit. So, I absolutely agree with his comments there.
All right, so Dr. Knobloch, you guys are teaching the next generation. Is this something like fracture reduction? Is that something that is part of your instruction?
We didn't do reduction. We did more. It was more of a stabilization. Vacuum splints, air splints, but soft splints. So I'm not comfortable now. Fingers I've reduced many times. Dislocations, not fractures. Shoulder I've seen it done 2 different ways. I have not done one myself, so I don't feel confident teaching something that I'm not. But I think it's more of just like they said. Dr. Aline said especially, was if you're comfortable in your training, they're not going to get that training from me because I don't feel comfortable and I don't know. There is the situation, you dislocate your shoulder, you compress the arteries flowing through there, you compress a nerve, the brachial nerve or something, that's possible. But they're going to get pretty quick emergency care in this case. And I don't think the compromised blood flow for that amount of time, in the 20 minutes gets to the hospital, and Dr. Lane, you could please tell me if I'm wrong because I want to make sure we get it right. But to me, that compromise is not as bad as if what could happen is if I reduce it and we compress or we sever an artery through a bone or something. So in my class, the emergency care, I don't teach reductions of fractures. I teach stabilization, take care of the patient, take care of the fracture, get him to the hospital. Now, actually, I could throw the question back at you. Would you teach? And I'm curious. Would you teach reductions, or what do you think in your background? Would you feel confident teaching that?
All right. So here at the high school, obviously it's different.
Mm-hmm.
I'm not. I would show if I was reducing, a thumb or a finger, something like that, and a dislocation. I would show the students because it's an experience that they have, and maybe they're at home and they dislocate their finger, their brother does something like that, and so then they at least have an idea of what to do.
Yeah.
But I'm not going to say, okay, this is the proper way to do this because I don't think I've been instructed this is the proper way. It's just been, doctors on the sidelines or, at clinics saying, this is how I do this. But nobody volunteers, again, to dislocate their finger or break their bones so that we can practice it.
I mean, and back in the 90s, I had gone through EMT training. We had hair traction splints and all that. And the standard accepted practice, I guess, was just stabilize it and get them to the hospital. Let the pros do it. Because if something goes wrong and all of a sudden they lose feeling, well, do I put traction on the bone again, maybe try and get that nerve free or what? Well, let them, get them to the hospital, let the experts do it, that if there's something does go wrong, the emergency care is right there for them. But that's my philosophy. That's not a standard. That's not taught across the board. I think a lot of it is your training level, like Dr. Allenye said. And so I don't teach them reduction of fractures because the other question is, how do you know it's even, is it displaced? Well, is there a gross deformity? Or is it, or what if they're an offensive lineman and just have a big leg, you can't see it? Stabilize it, get them to the hospital. Make sure you call 911 first. Get the ambulance on the way while you're going through all this. By the time the ambulance gets there, I don't really think the reduction is going to make a difference anyway. If the paramedics want to do it, so be it, or get them to the hospital. But I stress that's my philosophy on it, and I don't want to put them in a situation where they have to decide. Well, this is Dr. Knobloch said that if they see one leg shorter than the other and it's potential hip fracture, we should put traction on a leg. I'd rather them get to the hospital and go from there. But we have experts here that can tell you that what they recommend too.
All right, so in the EMT training, and Dr. Lee, you're talking about knowing the team, knowing who's there, and I guess it just comes down to you would have to have a detailed conversation. But in your opinion, is the athletic trainer going to be the one that should be calling the shots, or the EMT? And what are your thoughts on that?
Well, it's basically who knows the team better, and you need that good rapport at that time. So usually the EMTs, it may be this different crew at each game.
Right.
Mm-hmm.
So when it comes down to, let's say, the team doctors or the athletic trainers, they're the ones who have a good rapport and understanding. And as you know yourself, when I see some of the kids here, we're a team and a collaborative team together, and so we're always working with them, and we know a little bit of their history. And this all comes down to preparation. So it's knowing them before the season even starts, and knowing what their baselines are and how their health is in general. And so from a high school level, you're pretty much there for them. And you know them probably the most, even more than we do as physicians. Mm-hmm. And we only usually see them when they're ill for something. So, there's a great role for athletic trainers, and for anybody in a part of the healthcare team who's providing such care on a daily basis,
And I can speak as a former EMT. 6 months of training to get your certification to deal with any emergency care is just not what I think it should be. Now it may have changed since then, but also know, and it's not to me, it wasn't as big of a deal in a city like Houston. It's the small towns in the middle of nowhere where the EMT at the game is also and I don't mean to make fun of this, but this is a situation, is also the donut shop owner, and they're also an EMT, and so they come to the game, and for me to hand off care to them, I don't know if that's the best patient care available. When I have, 4 or 5 years of training or 2 years of intense training as an athletic trainer, sports medicine, emergency care, et cetera, for me to hand off that to that patient care and let them take charge and tell me what to do. Now, obviously, they have to transport them, but getting them on the spine board, assessing the injuries, I would feel more comfortable with the higher level training. But that's what you get when you get into the small towns is you have to have somebody there. And if it's the person that's had the 6 months of training and now they're an EMT, do you really want them providing care or telling you what to do when you, just like Dr. Lee said, when you have the rapport with this kid, you know him or her, and you have a lot of training at that level. So I think it's a judgment call. The last thing I've told people, whatever you do, don't get in an argument over standing over the athlete. Get it settled before. Meet them, greet them, say, hey, I'm licensed, I'm certified as an athletic trainer. Here's my training. It's nice to meet you. We love you being here. when I hand this athlete over to you, I'd appreciate, you taking care of them to the hospital. If there's a challenge to that, well, you need to have the conversation. But the last thing you want to do is have an on-field emergency and you two are fighting. I'm doing